Can you see my slide?
Yes, Doc.
Okay. Yesterday we talked about the history of medicine. Actually, it's not only family medicine, but the whole medicine, the history of medicine, and then we discussed about the biopsychosocial aspect, in which it's not, as I've said, it's not replacing the traditional way of taking the history, but giving us an output, again, an outview of a physician who is a compassionate, caring, and really know the needs of the patients. Okay, it just brings back. So for this part 3, I'm going to talk about physician as a healthcare provider. Okay, when we say healthcare provider, as physician, you should be equipped with the necessary skills, as well as the different aspects. You all know this, of how to take the history taking, your physical examination. Already you know about this because you're in the 3rd year already. The clinical and diagnostic reasoning, how we communicate, and then the prescription writing and assessing families in preparing healthcare plan. And this also includes healthcare promotion. Okay. As a physician, there must be a good doctor-patient relationship, which will be considered in the different ethical principles. For this part 3, okay, the objective is in order for you to know how to do the proper interviewing technique. Then the second is the family as a unit care, which the different family tools will be discussed, and then the healthcare plan. First, let me start with a case scenario. Okay. So dealing with patients and their family, this is being coupled with the correct diagnosis and management. It is really an important asset of a physician to have a good or effective doctor-patient relationship. Okay. The case of Marian, who is a 40 years old, diagnosed to have a breast cancer stage 3. And upon consultation, definitely she became anxious and asked her physicians, why me? Right? I think you already met this kind of patient. Okay. And the communication skills needed here are, we really have to ascertain patients' concerns and worries in the process of diagnosis, and then explain to them the treatment options, as well informing them on the nature of their illnesses, their therapeutic interventions that you might give to the patient, explain to them their side effects. And you, not only that, you have to address their psychosocial problems, and then counseling will be the next part. Okay. When you say communication, definitely this is a dynamic process. Okay. So it involves eliciting a desired response through our verbal symbolization. Okay. And this act itself, when you know how to verbalize, definitely it will involve the stimulus. The second is the perception and their interpretation, decision, then encoding all the data that you obtain. What's the message? Then the response, and then how to channel. Okay. These elements are always present in whatever form of communication used, whether this be verbal or non-verbal, or even use of symbols. When you say verbal communication, this is the most commonly used form, okay? And much of the time is the one that is being used much of the time in clinical interviews, okay? During the course of interview, the physician should use a vocabulary, remember this, you should use a vocabulary in which your patient can understand what you are talking. Okay? Do not use technical terms because definitely you can definitely your patients cannot understand you. Okay? Of what you are saying. The patient's education, beliefs, and even cultural background is really a factor here. In order for you to really in order for your patient to really understand what you are saying. Okay? The next one is the nonverbal communication. Your nonverbal communication, this is the communication often neglected during medical interviews because the concentration here is mainly on the verbal form. Do you agree with me? Diba? Non-verbal, the mannerisms, the eye contacts, the touch, gesture, the tone of voice and posture definitely sometimes are being neglected because you focus more on the verbal form. The eye contact, this will indicate whether the patient or you are sincere. This will have a a sign on you the sense of sincerity, okay? But it does not mean that the physician have to have a fixed stare in order to be effective, okay? Because sometimes staring straight to your patient might threaten your patient, okay? Your mannerisms, when you say mannerisms, this should be avoided. Why? Because they will really distract your patients while telling the history of the illness. The touch. This is also a form of nonverbal communication, which connotes that the physician wants to establish a sense of personal relationship with patients. Okay? Your gestures, they are done with ease so that it appears spontaneous and will avoid distraction. And your tone of voice should be modulated, again, in order to avoid threatening your patients. Okay? And your posture, definitely, uh, if you lean forward toward the patient in a relaxed manner, it will connote that you are really interested of what your patient is telling you. Okay? So the other one is the symbolic communication. When you say symbolic communication, this is the description of the external manifestation of both the patient as well as the physician. Okay? This include the manner of dressing, hairstyle, as well the social distances. Okay? As a physician, definitely one must dress professionally when going to the clinic and really have to maintain a comfortable distance in interviewing your patient. Okay? You must look professional in facing your patients. Okay? And the four commonly adopted communication skills are your listening, your speaking, the reading and writing. Okay? As again, the doctor-patient relationship, these are necessary in also in history taking, maintaining medical records, and the prescription writing, and also health education. Okay. Listening really requires a complex of the psychosocial as well as psychological factors in order to understand and retain the verbal materials presented again in what the physician is talking about. Okay? This listening plays an important part in communication and this cannot be done overnight. It really needs practice and identification with the speaker and organization of what is heard from the patient. Okay. Um, Remember that a doctor-patient relationship should be an active one, not a passive one. Okay. And this will now require the use of the different forms of communication as well as skills. Okay. These skills are divided into three clusters. Okay. You're listening, leading, and again, reflecting. The first is listening skill cluster. Okay. This implies a passive act, but actually it will involve a very active processes of responding a total messages. Okay. It's not simply listening to your ear, but you have to hear what the patient is telling you with your eyes on the body language, but a total kind of perceptiveness. You see, and this include the attending, paraphrasing, and perception checking. When you say attending, this now includes the greeting, eye contacts, posture, verbal statement. Okay, while you say paraphrasing, this is a method of restating. You are telling again what your patient's basic message in similar, but definitely in fewer words. Okay? The main purpose of this test is to test the understanding of what the patient has said. Example, you're still here with me? Okay, the example of paraphrasing the patient. Okay, my chest pain started last month. I just took paracetamol and it was then relieved. But it recurred last week and consulted at the health center. My ECG showed normal result. Now it comes on coming back. Okay, so as you are the doctor, will be uh, testing whether what you've heard is really the right one that the patient wants to relay. So this is the third time that you had chest pain and you can understand what is the cause. That is the example of you paraphrasing. Paraphrase, okay, restating of the basic patient's message. Okay, when you say perception checking, okay, it will help them clarify what you heard from your patient, usually over several statements. Okay, it is similar to your paraphrasing in content. The difference it lies on the interrogative phrasing. Okay, here is an example. An example of this is patient. My blood pressure is on the rise because I am bothered by a lot of things at home. The kids are very noisy and keep on running around. My husband is always shouting, even at little things. My mother is in law has a poker face. So you really have to check, okay, if you heard her right. So as doctor, you going to ask, you mean you have a lot of problems right now? Am I right? So it ends with an interrogative phrasing. Okay. So when you are presented with this case, you must know with whether it's paraphrasing, perception, or attending. The next one is the leading skills cluster. Okay. This is an this leading skills cluster includes your indirect leading, direct leading, focusing, and questioning. Okay. So when you say indirect leading, this will help patient get started and give him a cue to keep the interview going. Like example of this is that The nodding and hand gestures. These are your non-verbal communications, okay? Then you have a verbal statement like, what can I do for you? So it helps in your patients getting started to interview, okay? While you're direct leading, this focuses on the topics more specifically and encourages the patient to elaborate on what he or she is saying. Okay? And this can be used only if your indirect leading has been done. Example, so patient, Dr. Season, I've been having this chest pain for the last 2 weeks. So you will now ask, kindly explain to me the circumstances that led to your chest pains. So you focus on the topic more specifically. Okay. The next one of the leading skills cluster is your focusing. Okay. This is used when there is confusion now on the part of the physician because the patient now tries to mix confounding data. Okay. An example of this is that for patient, um, she will tell you that 3 days ago, based on the history, I have this headache. I also lost appetite. My hands seem to be trembling. And I experience it any time of the day. So there are confounding data, lipong. So as a doctor, you really want to clarify things because of some confusions. As doctor, you say, it seems that you have a lot of problems. So let us go over them one at a time. So let's talk first to your headache first. So one at a time in order to eliminate confusion. Okay? Are you still with me? So next is your questioning. Okay? This may be conducted in the form of open-ended or closed-ended questions, but it must be used appropriately. Okay? The different forms are your direct questions. Okay? And then your yes or no questions, confrontation, as well as probing question. Okay? Then we have reflecting feelings, reflecting content, and experience. For your direct question, it serves to clarify areas and add detail to the story so it can be answered with a word or a brief sentence, which is usually an exact data and gives the patient little room for explanation. An example of this direct question is, what is your name? Where do you live? What's your job? Okay. Then the yes or no question definitely are those answerable by either yes or no, or for obtaining the family history and then the review of system. While confrontation question, they are based on observation of the physician. Okay. Are you still with me?
Yes, Doc.
Okay. For the probing questions, okay, when you say probing questions, you have to explore definitely the statement of the patient. An example of this is that, patient, I have this headache since last week. It has become intolerable today. And then it's as if something is pressing on my right head. I self-medicated with paracetamol, but there was no relief. So it usually occurs when I am studying my lesson. So you as a doctor will explore the statement being stated by your patient. Okay. Aside from studying, is there any other incident that could have provoked your headache? Okay. You have to ask. So first is feelings. When you say feelings, observing this reaction and shares his deep concern. Okay, there are three areas of reflecting feelings. Okay, an example of reflecting feelings is the patient will tell you, I cannot understand why I am having this headache for 3 weeks now. Okay. My grandmother also had the same thing last year and she died of it. So you as a doctor will now reflect the feelings being shared. So you're afraid that the same thing will happen to you. Okay. So while you're reflecting content, it will involve the use of paraphrasing and perception checking. It will help now your patient expressing clearly by giving him words, a picture of what he said. Example of paraphrase and perception check, again, were given in your previous slides. While in the reflecting experience, okay, as doctors, you will ask, I notice that your hands are trembling. What does this imply? That is the example of reflecting feeling. Reflecting experience that is giving a descriptive feedback which relates to your observation of the patient. Okay. Now for communicating special situation. This is during the terminal illness and bereavement. Okay. Much of the difficulty here now in communication is in the case of terminal cancers around the diagnosis and prognosis. Okay. This needs a practice because some of the physicians here are afraid to disclose the bad news because of its consequences. Okay. So, since trust is really an important component in the doctor-patient relationship, so the attending physician should be the sole and primary agent in responsible for breaking the bad news. And the physician should be emotionally mature and stable and capable of giving empathy and encouragement. Okay. Disclosure should be done privately and be done when there is conclusive test already and that when the patient is physically and emotionally ready. Okay. The first thing that you have to do is the doctor should ask patient directly how much he knows about his illness. Okay. You will not go directly to them and then really have um, you have to ask them directly whether he or she knows about his illness. Okay. The second is the doctor should disclose bad news using emotive words with care. The third is he should discuss with the treatment options involved in in making decision making and plans. And then after that, there should be a summary of of the things discussed, and finally, patients should be given some information whether there's a support services that will really help the situation. Next is every patients really have patients manifest different characteristics. Okay, and the physician should know how to respond to a particular type, whether it's a demanding patient. When you say a demanding patient, usually resorts to hostile behavior, especially if the demand of the patient or the special significant others are not met. Okay? If they are not met, definitely they will be a demanding type of patient. The detached patient are those patients who does not care for any interpersonal contact and usually resentful that his privacy should be intruded. Okay? So, as physician, you should know how to establish rapport first in order to gain confidence. The other type of patient is your unhygienic patient. Okay? These are the irritating in appearance, but should not elicit in the physician the faintest dislike. The physician should carry out with his interview and later inform caregiver. Your caregiver should be informed that something has to be done with the patient's hygiene. Okay? While your emotional patient are those patients who over dramatize to seek attention. There are so many patients like this. Okay. And then the physician should address psychosocial issues raised because this might have a bearing on the condition of the patient. Lastly, you have your harassing patient. Okay. The physician should give positive feedback first so he could focus on the problem at hand. Okay? Compliance is one of the problems encountered in our practice, actually. So among patients who seem to forget the medication or their follow-up, the physician is in a firm position to influence compliance. Okay? So for the resolution now of the case, actually this one is the non-compliant patient is that the question should never start with why. Okay? And then you have an example here that you have to please take this to your patient. Okay? Most people find it difficult to take their medication. Then you have to ask her, did you miss any of your pills since the last time I saw you? Okay? So it's really very important to ask you, but the question should never start with why. Instead, it should be a face-saving, non-threatening, and non-judgmental for non-compliant patients. Okay? So, as case resolution, there is now dealing with patients and their family, coupled with correct diagnosis and management. So, this is an important now aspect of the physician. An effective doctor-patient relationship can make the difference between success and failure. So, the need for better communication will promote trust, rapport, and confidence on the part of the patient. Okay? Were you able to get to what these slides have been telling us about FAMNED? So before we go to families of a unit of care, okay? Any questions so far for the past lectures given?
So far, Doc, none po.
So far, none. So can I move on to family as a unit of care? Okay. So here now is the family is a unit of care. I'm going to discuss, our objective here is to discuss the basic concept of the family, the family systems theory, the life cycle, the impact of illness, and tools in family assessment and family healthcare plan. Actually, your activity will fall on this part, okay? Later, I will flash on the slide. I will flash on the things that you have to do for your reporting on Saturday. first. Case scenario. Belinda, 35 years old, married for 5 years, sought consult for lower abdominal pain with no other symptoms. Okay? Physical examination findings and laboratory workup show normal results, but the abdominal pain would come on and off. So no medications taken. On probing the psychosocial history, the physician finds out that she is having marital crisis, then she cannot bear a child. The husband is advised to seek consultation and found out that the husband has been having intercostal muscle pain and his mother has episodes of depression. So for basic concepts on the family, okay? It was Borges and Locke in 1960 who defined family as a group of persons united by ties and marriage, okay, interacting and communicating with each other in the respective social roles as husbands and wife, have the mother and father, son and daughter, brother and sister. There is a creation and maintain of a common culture. Another concept of family is by Rogers in 1973, where he defined as family as a semi-closed system of actors occupying an interrelated position defined by society by which the family system is a part and as unique to that system with respect to the role, content of the position to the ideas of kinship relates. Okay. Another is by Berman in 1978. He defines family as a small social system made up of individuals related to each other by strong reciprocal affections, loyalties, and comprising a permanent household, which has been persisting over years and decades. So those are the three basic concepts of family. Okay. Now, what are the types of families? Okay. The different types of families are the nuclear, where the members are your parents and the dependent children. They occupy a separate dwelling, not shared with the other family members of origin. So separate lang, not from the staying with your mother or father. So since you're married, you have a separate home, okay? The household is economically dependent and consists of from the occupational earnings of either husband or father. The extended type of family, this one is can be a unilateral extended or bilaterally extended. When you say unilaterally extended, it can be the wife's side, brothers or father or mother of the wife, or can be the side of the husband, his father, sisters, okay, brothers. While bilaterally extended, both family of origin are staying with you guys, okay? Both father and mother of both the husband and wife. This includes 3 generations, family-centered. They live in together as a group through its kinship, and the network provides support functions to all family members. Okay? Well, a blended type of family, this now the family where there are step-parents and step-children. Okay? They are being caused, this family emerged because of divorce, annulment, or maybe a remarriage from a widow, then remarried, or separation. Okay? What's the single parent is not, I forgot to place a slide here. A single parent family are those family who either the mother or father of the family are overseas worker. Okay, they are either the one left home, either the mother because the father is a seaman, or either father's left home because the mother is working abroad. So they belong to a single blended family. While the communal type or corporate family, they are a group of individuals formed for a specific ideology and considered as an alternative lifestyle for people who feel alienated from the predominantly economically oriented society. Okay. What do you think is a Filipino family? Here are some of the characteristics. Okay. The characteristic of a Filipino family is a closely knit, bilaterally extended, with a strong family orientation. Authority is based on seniority or age, and they are externally patriarchal, meaning the father heads, and internally matriarchal, meaning the mother is the one holding the household. Externally, it's the father, but internally, it's the mother. And this type of family or Filipino family, do you agree? High value of education of all the members of the family. Okay. So the characteristic, again, continuation of a Filipino family is predominantly Catholic, child-centered, with an average number of members of 5. And some of the environmental stresses or the economic, political, urbanization, industrialization, as well as health problem. Okay? Remember that Filipino family is a child-centered family. So the family systems theory, okay, the family-oriented medical care involves assessing how family functions plays a part in both the illness and health of its members. Okay, the concept here it emphasizes the interconnectedness of each one of us with their intimate environment, and is based on the following axioms that the family is a more than a collection of individuals. Okay? Families have repeating interaction patterns that regulate members' behavior, and an individual's symptoms may have a function within the family and the ability to adapt to change, and there are no victims or victimizers in the family. Okay? So these are the theory that will emphasize on the interconnectedness of each other with the intimate environment. Now we go to family structure. When you say family structure, okay, you think of the hierarchy, the boundaries, the coalition, alliance, and role selection. When you say hierarchy, it is how power or authority are being distributed in the family. When you say boundaries, these are the rules that will define who among the members participate in the subsystem and how they participate. When you say coalition, okay, this is the relationship between at least 3 people. Again, example of this when the mother and daughter collude against the father. Okay, there is now what you call coalition. While an alliance, this is a positive relationship between any 2 members of a system. Okay, while your role selection now is the unconscious now assignment of roles of each family members. For example, in the at home when someone's sick, now the mother takes the roles of being a nurse or a doctor in the home. Okay, that's a role selection. So next is after the family structure, now we go to the family processes. When you say enmeshment, definitely this occurs when boundaries are diffuse, as when the parents they have no privacy from their children, or when members are overly reactive to stress on one member and demonstrate a lack of individual autonomy. Okay? When you say disengagement, okay, this characterizes by boundaries that are too rigid, as when the mother and child subsystem excludes father involvement on parenting. While to your triangulation, this occurs when a third person is drawn into a two-parent system, okay? And the family patterns are the sequences of interaction that will now exemplify how the family functions. Okay, these are the different types of family processes. Now we go to the family relationship, interaction, and the effects of care. There are differences in behavior in the different ordinal position. I think everyone can relate on this. If you are the eldest, you are the firstborn. Okay? They are generally persevering, they are serious, more responsive to adults, and achievement oriented. Okay? These are the characteristic, general characteristic of firstborn. If you are in the middle child, definitely you are optimistic. Okay? Sociable, aggressive, and competitive, and occasionally manipulative. But if you are the youngest child, definitely you are demanding, outgoing, and most of the time negative, narcissistic, but you are affectionate. Okay, do you agree with that for those who are the youngest? Okay. Now, the parent-child interaction and the family, different family relationships and the class patterns. We have the upper class, middle class, and the lower class. The upper class are those who are more closely knit and great maintain in the family name more on the prestige. While the middle class are those who believe in hard work, who have initiative and independence, while the lower class sees life as a continuous struggle for survival. Okay? And this is a sign to a life of frustration and defeat. Okay? While your middle class is more highly regard of education. For the family setup, definitely for a democratic type of family setup, parents respect their child's decision and ideas, and there is understanding and permissiveness in the family. While you're authoritarian, definitely there is an like a military family, okay, and question obedience, conformity to parental guidance. The punishment is more than praise, okay? Patients with low self-reliance, suspicious of adults, stands poorly in stressful situation and become hostile and pain and discomfort. This is true with family who are in the military, okay? So the family life cycle, this one is a normal process of family development, okay? It involves sequence of stressful changes that require compensation and reciprocal readjustment of family members in order for them to be functional. Okay? Each stage now of the family life cycle is again associated with certain development tasks in order to proceed to the next stage. When you say unattached young adult, okay, it is at this stage that the young adult separates from the family of origin. Okay? He formulates a personal goals in developing as an individual, including now forming a family. While the newly married couple, they are the transition stage of the couple from the family of origin and their lives as individual to life as a couple. Okay? The table on stages of marriage, okay, with the corresponding emotional issues need to be done. Okay? This is under the newly married couple. The honeymoon stage is 0 to 2 years old, 2 years. Emotional issues, the commitment. This is the critical task, differentiation, making room for a spouse with family and friends, and adjustment of the different career demands. While in the early marriage stage is between 2 to 10 years, the emotional issues here are the maturation of the relationship, And the different tasks are keeping romance in the marriage, balancing separateness and togetherness, and renewing of marriage commitment. Okay. Well, the third stage is the middle marriage stage of 10 to 25 years. Emotional issues or post care review. Tasks are adjustment to the midlife changes, renegotiating, and renewing of marriage commitment. While the last stage is 25 plus year is the long-term marriage stage where there is the farewells and plannings. And the tasks here are maintaining couple functioning, closing or adopting family home, and coping with death of spouse. Okay, those are the different stages of a newly married couple. So next stage is family with young children. When you say family with young children, it starts from the pregnancy of the first child and it will continue to emerge to adolescent. And the coming of the children will now define a new family status as the wife becomes the mother and the husband the father. Okay? It is during this stage where the children start going to school, and which is their first contact with the outer world. The next stage is the family with adolescents. The three hallmarks in this stage are changes in the balance of responsibilities along with overfunctioning and underfunctioning. There is a marked shift in the intensity of relationship and an exchange of the community at large. So the three hallmarks changes in the balances of responsibility, okay, along with overfunctioning and underfunctioning, shift in intensity of relationship, and exchange in the community at large. The next one is the launching family. This launching type of family, it begins when the first child leaves home. Okay? And during this stage, the parent must develop an adult type of relationship between given children and themselves. Actually, our Filipino family are we are stuck on this type of stage of family because even if the first child lives home, okay, the last child stays with the family, and then even if the last child is married but still living with the parents, definitely we are stuck with the launching type of family. Okay, because it will now move only to the next stage when the last child who was staying with the family now moves out. Okay, and that is not the case here in our country. Family in later years, this begins from the departure of the last child, and this continues through retirement of one or both of the couple, and this stage ends when both are dead. Okay? Remember that each stage of life cycle, there arises a first and second order change as well as medical and psychosocial problems. Okay. The first order change is this involves the increment of mastery and adaptation, a need to do something new, or and this first order change do not involve the change in the main structure of the family or any change in individual's identity. There is now the addition of the existing state of individual's identity and self-image, which must be accomplished by the family and family members working in a stage of family life cycle. In your second order change, definitely there is now the transformation of individual, okay? A need to be something new, changes in the very basic attributes of the family. Because of the emergence of the children, there is now a change in the role and identity of family members. And this occurs between stages of family life cycle. Okay. Family influence on health and impact of illness. Okay. To better understand the patient's perspective, one really had to recognize the difference between illness and disease. And then the patient's experience an illness, whereas the physician will now diagnose and manage a disease. Okay. And then the experiences of includes everything in patient's life that is affected by the disease, and family has influence on the patient's health. Okay. And then the illness includes the suffer experiences of the disease and the broad range of dislocations felt by both the patient and the family. And this is deeply embedded in the social and cultural and family context of a person who is ill, while the disease is only a primary biological as well as psychological disorder. So the genetic influence, okay, will be on based on the family history. Some individual may be predisposed to certain diseases, and then the family is again the crucial in child development. There should be a relationship between childhood disorder and family dysfunction. The third influence on health and impact of illness is the infectious disease spreads in the family. Okay. The fourth is family factors that will affect morbidity and mortality in adults. Bereavement now is associated with increase in the consultation rate. And lastly, the family is important in recovery from illness. Family support really is an important factor in the outcome of all kind of illnesses, especially in the chronic and the terminal illness. Now we go to the family illness trajectory. Okay. There are five, take note of this. They have the five stages of your family illness trajectory. This is the passage through sufferings. Okay. The normal course of a psychological aspect of the disease for the patient and the family, the knowledge of the trajectory, which allows the physician to predict, anticipate, and deal with the family and response to illness, and be able to indicate normal as well as pathologic response, thus enabling physicians to formulate a special therapeutic plan. So you must know in by heart of what is going on between these stages. Stage one, the onset of illness. This is the stage experienced before contact with a medical provider. Okay, medical beliefs, previous experiences influence the meaning of illness. Okay, the warning signs here are body weakness, which initiates the preliminary stage of the illness trajectory, which is the onset of illness. And the nature of onset may play an important role on the impact of illness and family, and some meaning on the screen are formulated here. Okay. So the nature of illness may be acute, rapid. The nature of onset will be rapid, clear, characteristics, okay? And there is the impact on the family. If it's a chronic disease, the nature of onset is gradual, and the characteristic experience is there is uncertainty, okay, of the meaning of symptoms, and the impact of illness here is, if it's chronic, the seriousness of symptoms and the possible implication not only to the patient but on the family. So what will now be your responsibility of a physician? You have to explore the explanatory model and check on the fear of the patients and bring to clinical setup. and with an inappropriate label of illnesses, acknowledge and explore conflicts the patients may be experiencing, and now explore pre-diagnostic phase of the patient and families. Next stage is reaction to diagnosis. Okay. His present level of anxiety or shock. Now, physician will present the diagnosis, and he is responsible to making a clinical judgment about the amount of information that the patient can absorb. Okay? And then the disease and appropriate treatment can be described according to the patient's level of understanding. Okay? Then give a small doses of information over time, and if the diagnosis is confusing and stressful, okay, as physician, you must be able to provide support and continuity of care, be able to interpret the laboratory findings, offer advice and encouragement, and clarify what's the message, and then you really have to talk to them about the outcome of things. What are the emotions that takes role here? Okay, the emotional plane during the denial and disbelief, emotional upheaval. There is strong emotions like anxiety, anger, depression. And then lastly, your accommodation. The patient and the family now learn how to accommodate and be able to accept the diagnosis. That's in the emotional plane. While in the cognitive plane, the phase one, there is tension and confusion. If you are being asked what emotional cognitive plane in the phase one, definitely you must know that in phase one there is tension and confusion. Okay, that is the reaction of the family. In the phase two, repeated failure, now there is exacerbation of the tension, and their distress is increased. And phase three, there is now an increasing assessment and receptive. The family is now receptive and may be open to new approaches in order for them to relieve the stress. That is the cognitive plane. The other side of the table is the emotional plane, while the other side is the cognitive plane. And then the phase four is the then acceptance. That's part of the cognitive plane. So the responsibilities of the physicians here is the physician be able to help family members anticipate feelings and realistic effort to relieve the patient's self-blame through careful explanation of the cause of the disease. Okay? So you have to help family maintain the openness and allow sharing and support. And physicians should know that the feeling of guilt, this one is a natural response to stress, of grief, and loss. Okay? You have to assess the effect of illness in the family, predict problems, and the physician should be able to understand, uh, be able the family understand some points of the problems as well as benefits, and you as a physician should offer alternative interpretation of proposed therapeutic bolster of the family. That is the role of the physician and the impact of illness. While the stage three is major therapeutic efforts, where the physician will represent one of the most challenging and rewarding part of the medical practice. You as a physician should be able to deal with the multiple variables, work in harmony with the wishes of the patient as well as the family, and be able to coordinate all aspects of therapy, which will now involve the other specialty. Okay? The critical issues here is if the belief system and trust modality is at variance with that of the physician, he may resist attempt at education and reassurance because some of the patient's family are not emotionally equipped to undertake some form of therapy. So other professional help should be obtained. So referral to other subspecialty. Okay. Other critical issues here: assumption responsibility of care and the economy of therapeutic plan, and then the economic impact of illness, You have your emotional trauma, the social dislocation, and economic catastrophe. Definitely, this is the stage where the economic wipeout of family savings. Okay? Then we have the lifestyle and cultural characteristic of a family. They are important in choosing a therapeutic plan. And then lastly, the effects of hospitalization. Okay? Hospitalization now will give rise to father, special economic burden. These are the stressful problem. Mother, high risk for family dysfunction. Children, emotional problems. Parents, helpless, feeling of guilt, frustrations. For those elderly, vulnerable to fears of death, rejection, and loneliness. Okay? Loss of a member will return position upon return, and conflict between family and hospital staff may be intruded. So, the responsibility of a physician here is to remain to the family, to remain open to the family, deal with the different factors in planning, work in harmony with the patient and family, coordinate, and then anticipate. The last stage, okay, I will end on this stage because it's 8:15 na, is the early adjustment to outcome. This is now the recovery, okay? This is where the patient return from the hospital and then experience the recovery or adjustment to the illness outcome. This one is an important phase for patients and family. Okay? It usually varies according to the type of outcome anticipated. Okay? The simplest outcome is, again, return to full health, thus gain from illness experience or partial recovery, followed by a period of waiting. And then recovery is quite different if it requires acceptance and no permanent disability. Okay. Responsibilities of the physician is, again, deal with the imaging effect of trauma, alleviate anxiety, psychological support, okay? And again, you really have to explore level of understanding of the patient as well as the family and whom to call for help among the family members. Okay. Stage 5 is the adjustment to the permanency of outcome. This point is the family's adjustment to crisis. The second crisis occurs as family realizes that they must accept and adjust to the permanency of the disability. Okay, as a family physician, you should be aware that continued unwillingness to incorporate the reality of the permanency of the loss may be a sign of pathology among the family members. For acute illness, okay, potential crisis, especially when the family routines are suspended. Emotions here are very high and can lead to anger in the family if the family perceives that the care given by doctor is not satisfactory. So really, the suddenness of illness, it will really find the family difficult to face the stress. As the family physician, you have to facilitate health response in order for the family to accept the diagnosis and be able to recognize the danger signals. Okay? For chronic illness, definitely there is the higher incidence of illness in other members of the family. Anger and resentment toward the sick member sets in leading back to feeling of guilt later. What the physician can do is then encourage ventilation of feeling and giving reassurance and reinforcement of care. Okay? For terminal illness, highly emotion, potentially devastating, definitely there is now the family might go into dysfunctional one and can be the seed for future family discord and breakdown. What the family physician can do is assist the patient and the family and then aid the patient and the family in efficient and functional readjustment and then provide quality of care. Okay? And for family reaction to death, in after a prolonged severe illness and adaptation and reaction are already accomplished, death comes swiftly, And then the physician assists family to cope with the stage of denial. This is few days to few weeks. Prolonged if pre-morbid pattern of abnormal behavior is seen. There's anger, then the next is depression, bargaining, and then acceptance. Okay, I think I will end here.